Welcome everybody, my name is Janet Probert and I'm the programme lead for the Healthy Ageing agenda. We've got a fairly full agenda today. Dan, you're going to start off by taking us through the key updates.
Yeah, absolutely. So what I'm going to do is just run through some slides on latest stuff that I've come across over the last 6 or so weeks. Obviously, it's not comprehensive in any way. It's just some interesting things that I've noticed over the last couple of months around frailty that started to emerge and come out and things. So the first thing I want to highlight is just a bit of frailty and the COVID-19 situation. Obviously, there's a plethora of information coming out around frailty and COVID-19, but a couple of things I just wanted to highlight here is obviously the importance of delirium and COVID-19, and a couple of articles that have been produced recently looking at sort of the importance of recognizing delirium in older patients presenting with COVID-19. And if that's not right up on our radar, we are going to miss a number of cases of people with delirium in older people. So I think there's a bit of discussion there in a couple of the articles urging a sort of possible rethink around sort of the diagnostic criteria around COVID-19 and older people. So they're quite interesting reads for people who've got a bit of time. Then I just wanted to look at, I think last time we talked a little bit about the clinical frailty scale and mortality in COVID-19. And we talked a little bit about the use of the clinical frailty scale in the acute setting for ceilings of treatment and the NICE guidance that have been published. Well, clearly people have been looking at this in a lot more detail about how important and how useful the clinical frailty scale is in helping in decision making. And I think the overall consensus, it's like anything, you really shouldn't be using one tool in isolation. That's a given. But they have looked at sort of clinical frailty scale and mortality. And it's an interesting sort of subject area. But this latest sort of results of the COPE study that's just been published do suggest it can be quite a useful tool to inform decision making in people who are presenting with COVID-19 and the elderly people. But then I was on a webinar listening to some other colleagues and some information merging out from sort of London and Leicester and other hospitals, looking more closely at the clinical frailty scale, frailty, and the COVID-19 and mortality. And even though we know in sort of non-COVID sort of situations, the clinical frailty scale and frailty is linked very closely with poor outcomes and mortality within the hospital setting, there seems to not be such a positive sort of direct correlation with the clinical frailty scale and mortality. Yes, they do worse, but they're trying to unpick why the people with the low clinical frailty scales are dying just in the same numbers as those with the higher clinical frailty scale. So I think a lot of the academics and clinicians who work in this area are trying to unpick maybe the pathophysiology behind frailty and why we're not seeing that direct sort of correlation and things. So I think it's just something to watch and be probably mindful of over the next few months, see what emerges from that. The next slides I've put up is I've just tried to link some useful things that have came out in the sort of acronym of iCare, really. And these are things that people may have came across in your reading over the last few months and things. But under the sort of involve section, Age UK have produced an interesting article about looking at the future care of older people and on the back of COVID-19 and funding and things like that. And it's certainly worth a read. Adult social care and everything we've talked about care homes, social care funding, reshaping the future. There has been a recent document produced by AHSN, and they've put out quite clearly 9 statements of change they think would be needed to reshape adult social care in England, and that's obviously a policy sort of document for the government to take on board and have a look at. And it's interesting. It's quite high level, but useful. Possibly not rocket science. We've probably heard this before, but it's useful to see it written down in the context of obviously what's been happening over the last year or so. Then a couple of other things under consider. There was just an interesting, dare I say, quite a medical sort of paper looking at frailty and the concept of sort of physical frailty in this thing called sarcopenia, which looks at sort of the mechanism behind frailty and things. And they've actually looked at sort of teasing out physical frailty and sort of weakness and sarcopenia and see if that would help us understand and predict outcomes for people with levels of frailty. So for those people who like getting into the pathophysiology of frailty, that study is quite an interesting one that's been going on and underway. Under the assess section, a couple of interesting articles here. The first one is looking at trying to think about the point at which people with a certain level of frailty may warrant a more comprehensive sort of needs assessment. And what they've tried to do in this study and what they've tried to develop here is link the electronic frailty index that's in the computer systems of sort of primary care and try and link that with the comprehensive geriatric assessment tool. So looking at at what point would you initiate a more comprehensive assessment of need depending on the level of frailty of individuals. And that's quite an interesting article to have a read of. And the final thing just came to me really this morning. It's some of the work that's being done down in Durham, which is looking at how we sort of case find people with certain levels of frailty who then warrant sort of targeted type care or interventions or support. Because as we know, there's no perfect sort of tool out there that's all encompassing. And the work in Durham, which has just been published in this article, looks at a sort of case finding protocol where it pulls together different sort of criteria and helps categorize people's level of need that warrant sort of targeted intervention. So that's worth a read. And the last couple of things under the response section, a lot of information out there on the NHS England website and some other information there from CQC and everything, and a report from sort of IRIS looking at social prescribing case studies in light of sort of COVID. That fits under a sort of community connectivity. So that's worth a sort of an interesting read, looking at sort of local areas around the country, how they've responded to COVID-19 from a community connectivity, social prescribing concept. Long-term condition management. There's obviously the British Geriatric Society actually a few months ago wrote an interesting summary for the primary care networks that are trying to set themselves up to sort of operate and support people with different levels of frailty. So I've popped that in there for people to have a look at. And finally, there's a tool that's just been released for a fingertip sort of tool for Public Health England, looking at sort of 60 millions within sort of dementia care, which is certainly worth interesting for people who work within the dementia field around frailty. And last couple of things, you're probably aware that we're now into this sort of response and recovery phase, and NHS England have started to write about your COVID recovery and how local areas can start thinking about sort of rehabilitation services in light of sort of the demand that clearly may be on the horizon following COVID. And final thing is just some webinars I've been following over the last month or so, and it's from NHS Elect, the Acute Frailty Network, and what they've been doing from a hospital sort of perspective, they've been following a person called Mrs. B through her journey of admission to hospital, through the hospital system and back out. And that's quite short webinars, quite interesting, 20, 30 minutes, just following the different journey of Mrs. B through the different stages of being admitted to hospital, then being rehabilitation back in the community. If anyone wants a little read of that. Last thing, British Geriatric Society have just released this sort of frailty hub that seems to have a lot of learning and resources. Some of it is sort of accessed by registration, some of it's readily available, and they're categorizing the sort of resources and the learning over these sort of 6 areas, which is all self-explanatory when you go in, sort of cater for people who work in different fields within sort of older people's services and frailty and things. So that's really just a bit of a summary of what I came across over the last couple of months around sort of frailty, some touching on COVID, some non-COVID stuff and things. And I just wanted to share that really with people and give you some links to have a further read at a later date.
Dan, that was great. Is there any questions for Dan on the presentation? Because I know you've got a few more things to share with us. So I just want to see if anyone's got any specific questions on that at this stage, Dan, or else we can carry on.
Absolutely.
I'm going to always take mute and no response as absolute happiness. So on that basis, Dan, I think you can carry on.
No problem. Okay, so I now wanted to give you a little bit of update, and I've got a few slides from other people who can't attend based on some local work that's currently sort of ongoing at the moment. And the first bit was just to, people might be aware that we got some funding to try and think about how we can develop a sort of a digital comprehensive geriatric assessment tool. And the aim for this was really to try and support local areas, practices, PCNs, wider communities for thinking about how we manage people with moderate to severe frailty and try and help them work together in an MDT type environment. And our aim was trying to scope out really what a digital interoperable CGA tool could look like, and then eventually test that in a couple of areas across the region. So work is underway. It's being led by Health Call, and Fiona Codwell's leading that for us, and she's been speaking to quite a number of people from different specialties around the comprehensive geriatric assessment process. So we're at the point where we're scoping out the content and the fields within the CGA, and we're now then going to explore where we could probably test this tool. Mindful that probably it's a big piece of work. We don't want to duplicate what's going on, and we certainly want something that supports areas that are currently doing this work and underway, trying to deliver on some of the sort of recommendations and some of the guidance that's out there. So I'm hoping probably over the next month or so, we get to a point where we test this comprehensive geriatric assessment tool in a couple of areas across the region, probably within PCNs to help the MDTs operate, and see what learning falls out of that over the next 6 months or so. So we'll keep you posted. And if anyone's got any specific questions about that, I can certainly put people in contact with Health Call, or you can certainly join the conversation that we're having around that. But you may well get some invites or had invites already. The next thing is just a slide from Leslie. You can't join us today, and you're probably aware that quite a bit of sort of research proposals have been going on. Some are being delayed and waited for post-COVID to things get back started. But this one is looking specifically at sort of resident populations in sort of sheltered housing schemes. And I think the real rationale behind this is, I think we all recognise that people living within sort of the care home environment are quite diverse and have varying needs. And what we want to do is now explore people living within the shelter housing type schemes. So Leslie's working with some colleagues, I think one in Newcastle and one in North Tyneside, and some practices to start to tease out some of the demographics, some of the sort of needs and some of the sort of utilisation of services within the populations within the sheltered housing scheme. And I think this really is some of the bedrock and the foundations to other bits of work that's going on, because you're probably aware that they're trying to create some digital profiling tool that will link in with obviously this information gathering exercise. And also there's a national sort of longer term study underway. Leslie's put some of the names down there who's leading that we think this work, once we get started, will feed directly into. So it's really looking about understanding populations and how we can then shape workforce based on need and targeted interventions rather than blanket policies and things. So I think it'll be very interesting to watch that. And finally, a little bit of an update from the metrics from Andrea Brown. She just sent me this morning, but I think last time on the community of practice, Andrea talked about a couple of things. The first thing that I want to highlight is we've done quite a bit of work trying to understand sort of risk factors for frailty. And I kicked a bit of work off looking at this and passed it over to some of the sort of academics and Andrea and them in NEQOS. And what they're going to do for us, and I'll come on to this later when we look at Jackie's story, they're currently pulling together sort of a comprehensive evidence base behind sort of risk and risk factors for frailty. And then what we want to try and do is convert some of that sort of intelligence into understanding some data and information around potential impact with interventions. And some of that work will feed into the wider metrics that we've got on frailty eye care and some of the work that I'll mention later on Jackie's story. So Andrea estimates that the first bit of the exercise, where we pull together sort of risk factors in frailty, it will be done. Then we're passing that on to some business intelligence colleagues to pull off some of the data related to local areas within the Northeast and North Cumbria. And Andrea mentioned a couple of other things, that she was also doing a bit of work with NEQOS and the Academic Health Science Network and Public Health England, where they were really trying to look at some sort of metrics for the impact of COVID on sort of referrals, screening and activity generally within the NHS and Public Health England. And that work's underway. It's not specifically related to frailty, but clearly there'll be subsets within that work that we'll be able to utilise and tease out that is directly linked to older people's services. And she's suggesting that by the end of August, actually, the first report may be done. And what she's mentioning here about looking at frailty and trends, I think she's continuing to look at that over the next few months. And there seems to be, it looks like there's a meeting going on in September where she'll be looking at the trends to sort of the frailty metrics over the next, or what has been happening over the last year and things. We'll give you a bit more information about that, because I'm not sure what that event's all about really, but we can get some more information from Andrea and share that. And the last big for me, so I will be quiet, is really looking at Jackie's story. You might remember that around sort of the frailty eye care, we had this person called Jackie, who was a real life person in the Northeast and Cumbria. And what my ambition was to always sort of tease out a person's life journey along that sort of frailty spectrum, and then support sort of professionals to offer care and support for the person, their family and the carers. And so we've been working on an infographic, and some people have seen this already, and trying to tease out this Jackie's life story. And I'm going to show you probably a section of it, and we're going to have a further chat about it, but there's still work to be done. We're looking at sort of introduction and ending videos. Clearly, we're looking at sort of impact locally and some measures locally, what I talked about earlier from Andrea's work at NEQOS and in the business intelligence people. And we're looking at an overall review just of some of the narrative and really tightening it all up so it looks a little bit smarter and neater. But I'm happy to just go off to share that now, Janet, if we're at that point.
I think that would be sensible. I don't, anyway, just check no one's got any questions on the section we've just talked about in terms of local updates. There'll be plenty of time for people to pick things up anyway during the meeting, but I think it's if you carry on, Dan.
Okay. So if I get lost, I'll see how we go. I'm going to stop sharing that and see how we get on with this.
We can all hear you clicking away, Dan.
So I'm clearly not going to go through the whole infographic itself, but what I thought I'd do is just show you a little bit around the sort of the website and probably play one of the frailty areas, and then probably have a little talk through some of the sort of sections. So we've got this person called Jackie, and what we're going to try and do is take the reader through a sort of life story of Jackie. As I say, still work to be done, everyone, but that's where we're at. And we're just basically looking at how it all links together with Frailty Eye Care website. So if we want to start, I could probably start with the mild frailty section. So I'll play the video first, and I'll have to take my headphones out, I think, for everyone to hear this, okay? So bear with me. Please tell us, shout up if we can't hear the actual narrative. And this is a continuous video, so mild frailty. Do bear with us, there's work to be done, okay?
A major change occurred for Jackie at age 77 when osteoarthritis in his right knee forced him to stop working. At 79, it was planned that he would have a knee replacement, but before the operation he got a blood clot in his lung. The medication for this meant his knee replacement had to be delayed. Medication completed and waiting for his knee op, Jackie suffered a stroke. This left him with mild weakness in his right side, which, together with his chronic knee pain, restricted his mobility and left him reliant on a walking aid to get around. Not long after this, he suffered his first fall, but returned home to the care of his wife.
So that's just a little brief video for mild frailty. I'm just going to plug my headphones back in, bear with me. And we're still working on some of the narrative to explain the little headings that came up at the end there, and obviously some of the work that still needs to be done. But what this does really, it takes people through the sort of the eye care framework. So the involved section, and obviously we can link off to the website. Then this is where we've done quite a bit of work on the consider section. So trying to support people to always think of sort of modifiable risk factors around frailty or some early warning signs. And there's clearly more detail on the eye care website, but if you click into sort of chronic pain, we're trying to give people sort of ideas about the links between risk factors and frailty and vice versa. So this is just more information that'll all get tidied up, but will be available with links to the evidence and things going forward.
And Dan, to be clear, those links are relating to mild frailty, aren't they? And they're different in each section.
Absolutely. So each section has the consider factors and what's related to that sort of level of frailty. I think we all realise that it's not a perfect box sort of situation, but this is probably the best fit type scenario for the journey across frailty. So there'll be information, so if people are working on, so the assessment will obviously be the clinical frailty scale and moving through. Then when you look at the sort of response section, clearly this is about community connectivity, and what we've tried to do is pull together what sort of community connectivity, social prescribing does from a what seems to work very well from the evidence. And then when we start to look at evaluate this, where a lot of the work needs to be done, we're going to then pull out the sort of benefits that people can see related to community connectivity and trying to prevent frailty or minimize the impact of frailty, and then look at sort of impact. So then finally, resources and all the links to sort of the evidence base and things that we've looked at under the concept of mild frailty and the response section. So as I say, it's a little bit wordy, but it will be cut down, and each section will have that with more information on the iCare website. So it'll be useful really for sort of health and social care professionals looking at whether they are dealing with at an individual level, whether managers or frontline sort of providers are trying to set up pathways around sort of severe frailty or moderate frailty or an older person generally, and hopefully just give them some of the resources that they can use and some of the evidence base and impact and outcomes that they could probably use for these services. So it's very much a resource tool. My aim would like to really try and get this all finished from a content perspective and a technical perspective over the next month or so, realistically, then really share it and think about sort of usability and modify it and get it out there and things to see how we can start using this for frontline people. But as Janet suggests, each section clearly has information around the different areas of, clearly, if you just look at bereavement, somebody who's bereaved, there certainly is a significant risk factor for mortality and sort of frailty and things. And it's stuff that probably I've learned a lot of by doing, actually trying to put all the evidence base together and things. So that will be hopefully ready for sharing, for learning, for tidying all up over the next month or so. So that was just a whistle-stop tour of Jackie's story that we're trying to work on.
Dan, can I be clear? This is still at the stage where people's input would be really welcome, wouldn't it? So if people follow the link that will be shared with this presentation and can have a look and give us any comments or anything that would be helpful, that would be really valued, wouldn't it?
Absolutely. This is the, I think, the third version of it. The fourth version that hopefully will be getting done over the next couple of weeks, we're just trying to get the narrative together, will be probably a lot more complete, and then people can certainly just follow the link, and we'll be sharing that to all our sort of our COP members for giving us feedback and things on the video itself, how it all fits together and things. So you can certainly comment on this one, but I think the next one will probably be where it needs to be. I'll be happy with where it needs to be before sharing, and then feedback as much as you want on that one. But if you feel like you want to give us some comments on that one, on this one, go for it.
Thank you, Dan. I'm not seeing anyone put any comments in the comments box. I just need to check, does anyone have any questions for Dan on Jackie's journey? I'm thinking that's a no.
Hi Janet, it's Paula. Sorry Janet, it's Paula Swindale here. I've put my hand up. I don't know whether it's showed or not.
It hasn't shown on mine. I don't know.
I've got Paula's hand up.
Hiya, Dan.
Anyway, go ahead, Paula, hand up or not.
All right, okay. It's just a quick one, Dan, really, because I'm just sort of re-engaging and coming out the end of some of the COVID work. But we've done a lot of work with primary care around the Frailty Index, and now I'm noting there's the CFS score, which seems to be, is that new, Dan, and how is that going to link with how we're targeting the people in primary care, because we're doing a lot of work with GPs around the Frailty Index and identifying frailty. And then I've just noticed in the new chronic frailty scores there now, which will be differ from the Frailty Index, or are they the same? I'm just kind of, and I think the video and everything is really, really good and helpful, but when you've got that score at the top, we've got, if we're working across the system, do we need to do some more work around that?
No problem. It's certainly a political and quite hot topic debate.
Right.
But when you say you're working on the Frailty Index, are you talking about the electronic Frailty Index, Paula, within the GP systems?
We are, yes.
Yes.
So what trying to do is some targeted work around the moderate to severe, and we've built in various LISs and, you know, local incentive schemes, etc., and DESs around kind of targeting that element, really. So if somebody's in the severe, obviously it gives a score, but now I'm noticing the chronic frailty scores coming out, and it's just where's all that going to fit going forward? But
absolutely. Well, if you look at the whole evidence base behind the EFI, because we've had real big debates about this over the last year with the national team and some local areas. If you look at what the actual guidance is around the EFI, what that does, it'll probably give you a list of patients who electronically have been considered within them different categories. Yeah. But if you dig down deeper, the guidance always has suggested that the clinical frailty scale should be the confirmatory sort of test as such for confirmation of that list. So you're absolutely right. And if you look at our Frailty Eye Care, we've got the EFI on there as a sort of population tool for pulling off your lists. Yeah. But then really for individual management, the next step is the clinical frailty scale to confirm it, and then go on to confirm and categorize it, really. That's what the whole clinical evidence behind the clinical frailty scale is, for categorizations of levels of frailty. And then onto the sort of targeted intervention. So practices should have been, if they've been pulling off the EFI lists, should have been then doing confirmatory clinical frailty scores on them lists, and that's a debate in itself. That's what the national team always wanted to happen. Yeah. There's obviously been a lot of controversy about blanket sort of pressing the button and just getting lists of patients. And then there's a whole nother debate around the EFI itself, the clinical frailty scale itself, and whether really they are sensitive enough and missing certain groups. So there's a link on my page where Gareth Forbes has actually just got a published paper on case identification of sort of people with frailty, and some of his criteria is using, which is using the EFI and the clinical frailty scale, but he's adding other stuff to it, is giving a little bit more sensitivity and specificity for the moderate and the severe. So it's certainly something that's currently being debated. Right. But it certainly fits. The CFS should always really be sitting alongside the EFI. Yeah, yeah. We have over the past seen the different scales being used, such as the Edmonton, etc., but it's just getting that standard approach, isn't it, to categorise once they've done the EFI. But that makes sense the way you've described that, and that you're right, that is another level, isn't it, of expectation. Yeah, I think Jenny's trying to get in.
Yeah.
Sorry, Jenny.
Sorry, no, it's okay, it's Jen. Yeah, you're absolutely right, Paula. I think we should also just clarify that the CFS is the same as Rockwood. The two are interchangeable. So, right. And I think you get confused. So it's absolutely what you've been doing, Paula.
Right, that makes sense now you said the Rockwood, because I was thinking, is the CFS another thing?
and I think actually that's a very good point to make, that Dan, etc., we need to take back, because consistency of language is absolutely essential. And so CFS and Rockwood are the same thing.
That makes sense. Thank you. I thought I was going a bit mad.
No.
That you were thinking you were on a different planet, but you're absolutely not, Paula. Don't worry.
Thank you, Jenny.
Yeah, not at all. We've had long debates around all this for a number of feels like years now, but
can you hear me?
yes.
Yes.
Oh, that's good. Sorry, I thought occasionally our Wi-Fi is a bit temperamental, so I do apologise for that. So, any other comments or questions for Dan on this presentation? Well, I think that's been really helpful, and I think the key point from Dan's presentation is there's lots of information, there's lots of links there that hopefully are useful, but feedback to us is really grateful. You know, the community of practice is about the sum of its parts, so we try and provide information into the group, but it's really important, like the conversation we've just had with Paula, that we can have a conversation about where this fits locally and how do we use it to make a difference. Dan, looking at the agenda, have you covered all the things you were hoping to? I feel we've covered the issues on the agenda. Is there anything else you want to add, or we'll move on to information sharing?
No, I'm happy with that. Probably I've got something on information sharing I'd like to throw out to some of the mental health experts and things, but we'll wait till we get onto it.
Okie dokie, that's great.
I've lost you.
Yeah, Janet, I think we've lost you. Can you still hear us? No, I don't think she can. Dan, do you want to pick up the next bit about the did you want to bring in what you were just going to say about
absolutely. So
really, Janet picks back up.
No problem. We just wanted a little bit of a time for sharing what we've all been doing. One thing that I've came across recently and I'm trying to grapple with and struggle with is probably what Paul has been mentioning. If we look at sort of risk assessment of people and trying to categorize people, there's a lot of work going on within the PCNs and trying to develop their MDTs and deliver the care home model. But that care home model actually does include some facilities where we have people with LD and autism, and also have people with significant serious mental health problems. And some of these tools and things that we've talked about under the older person's umbrella and frailty don't necessarily fit with the younger population or people with LD and autism. So it's just to really throw that out there, whether anyone's got any ideas about how, or if aware of any tools or any sort of information that's quite useful for practices and PCNs as they move forward, trying to categorize and risk stratify as such.
Karen, do you have anything? Karen, did I see you on?
Not that I can think of, but then obviously I work predominantly with older people, and you know, most of what we're talking about is relevant for my population. I can ask around.
If you wouldn't mind, because I think what we're finding is certainly within the kind of enhanced health and care program, that there is much overlap, and the expectation is for things to cover the LD population. So we don't want to, you know, we want to be very open and incorporate any care planning or risk stratification where we can, so that we can make, because in essence the teams on the ground, or many of the teams, certainly from a primary care and community services perspective, are going to be one in the same. So we just need to be as simple as possible, really.
Yeah, I'll do some asking around. There's a learning disabilities network as well as one of the, in terms of the NHS England clinical networks. So there's a, you know, sort of same area as us, learning disabilities network. So they might be helpful, because obviously for a lot of people, particularly these days, a lot of the mental health learning disabilities is largely to do with the mental health element of people's learning disability rather than their so much holistic care. So I don't want to be being sort of pulled off in that direction, when actually we're talking about trying to provide more holistic care. But yes, I'll ask around, and I would suggest maybe we, whether together or what, approach the Learning Disabilities Network as well.
Yeah, I think that's a good suggestion. Dan, if you finished with your slide set, can you take it off? Can you unshare it so we can see people again? Or it might just be me that can only see your fabulous slide.
Has that came off?
Yeah, it has. Yeah. And Janet, I think you're back. So I'll hand the chair over. I'm
really sorry about that. Apologies. So I think you probably started on the sharing of information as to what people, in terms of the frailty agenda, wanted to put on the table, or any questions people wanted to ask. This is never as easy to do, I don't think, on a Teams call as it is when we're all in a room together. But I have made a list of everybody's names. So I thought I might just, if you're okay with it, just whiz down people's names and just ask people if there's key things that are going on in their area that would be helpful to the rest of us, or key challenges that people would really value other people's ideas on solutions. Is that all right with everybody? The people I can see are nodding, so I'm carrying on. I'm going to start. I'm just going to go on the list as the numbers come up, but the first person on my list is Joanne Bell. Joanne, do you have anything you want to either share or ask?
Hi, no, I don't have anything to share. We've been working with CDDFT around some of the frailty stuff, and we're offering support into the proposals of having elderly wards in Bishop Auckland on Ward 7 and Ward 10. So we've offered to support with the Sterling kind of dementia work around environment. So we've done that. So we're going to be working with you and around that, and there's some more meetings planned.
And I think it'd be brilliant if you can keep us up to speed with that, Joanne, because that is the sort of thing that other people will find really helpful in terms of any learning that can be shared across the patch. That's fabulous. Lindsay?
Just unmuting there. I'm really here on behalf of Leslie. So I think Dan's already shared the work we're probably going to do as part of that research project into one of our extra care schemes. I think the only other thing to say is we've been running the Innovation Village research project with Northumbria University, looking at technology and how that supports customers with mental health, older people and learning disabilities, and that comes to an end this week. And we've got a lot of really good outputs from that, which hopefully we'll be able to share once we get the final report.
Lindsay, it's great to hear that you're in post now, because I think the project's taken a little while to get off the ground due to the sort of challenges of COVID, and you're all starting to be able to do that work. Yeah. Is there anything particular that you could give us as a heads up at this stage?
Just in terms of the research project that we've been running for a year now, I think Glenda Cook's probably the best person to feedback, but we've been looking at a lot of simple assistive technology that can aid skills and independence for our customers. I'm particularly mindful of those people maybe who have cognitive issues due to dementia. So we have come up with also potential for something called Introvox, which allows us to personalize voice commands through the likes of Alexa or Google Home to make it much more usable for some of our customer groups. So there's a lot coming out. It would take a long time to give you all the highlights from that, but Sunderland Council have got further funding to take certainly the Introvox forward to hopefully get to the point where we can actually commercially develop that product.
And that's fascinating, and it'd be really nice when you're at the right point to brief everybody on the key findings. So thanks for that, Lindsay. David?
Yeah, we've got lots of irons in the fire. Getting the end product on them is proving a bit difficult. So, but some of the strands of work that we're doing then. So we use Nerve Centre in secondary care, a digital platform. So all of our patients over 65 are now having a CFS done on admission, and that's going really well. Andy Chaplin and Chris Mull had needed to do quite a lot of work on making sure the accuracy of that. But the staff in ED are actually using, the NHS Select CFS app. I don't know if you saw that they put that out, that you can download on your phone. And that's really improved the accuracy of the ED staff doing that. Last Tuesday, we went live. We've been doing a pilot for about a year. And we went live last week, so we are now screening everybody over the age of 65 for delirium using the 4AT on admission into hospital. So that's in place. We've now got, you mentioned the webinar that was had about the NHS health call and CGA. I think Fiona's going to come and see us in North Cumbria just to see. We've just kind of been pressing ahead quietly with our internal system on Nerve Centre. So we've now got a CGA profile in there, and 2 bits of work. So first of all, we're about on one of our elderly care wards to start using that to inform MDT meetings and discharge planning sessions, and then also looking at how we can export that on discharge. And then the final big bit of work we're doing is just starting a pilot training a couple of our wards with the NCOP, you know, the Enhanced Care for Older People competencies from UNN, from Juliana and Sue Tiplady, which is, again, it's a little bit behind because I think Angela Fraser and some others who were recruited in to do the competency training, that's been delayed a little bit. So yeah, all go.
Sounds like lots going on, and it is great to know the workforce work is now starting. Again, that's another project that has been a bit delayed, but no, and it sounds like you're doing lots in different areas, David. You must be juggling like mad.
And then some fall stuff as well. So
yeah, it's fantastic to hear. Are you happy for people to contact you, David, if they're looking at any of those areas? Because I'm conscious with the British Geriatric Society app out this week, you know, a number of people might be looking to use that and might be interested in other people's experiences and things. So that it's great to hear that's already being used. I think it was only launched earlier this week, wasn't it?
Yeah, I mean, I just obviously, or as people do sometimes, you know how you prepare for meetings kind of at the last minute sometimes. But I was just having a conversation. I'm not proud. It's just life. But I had a conversation with Chris Mull and Andy Chaplin, one of our geriatricians and practitioners. And I just asked them how they were getting on with that validation of the CFS. And they were saying, since they used that NHS Elect app, the accuracy of it had improved. We were using that to either stream people to a frailty assessment service or ambulatory medicine if it was above 5, and so people tended to either have a score of 5 or, you know, it was just a bit like hit 5 and send it there. So now we're getting a more accurate spectrum of scores.
Yeah, that's really good to hear, and it'd be lovely to hear some feedback at the next meeting about, as that gets embedded, what you're starting to see in terms of clinical practice, David. But fantastic, thank you very much for that. I'm going to move on if that's okay. Emma. Emma Fleurs, are you there? Oh, yes.
Sorry, just unmuting myself. I don't have anything particular. I'm just really attending on Nicola Allen's behalf from Gateshead Community Services. But I think just the main thing for us really is obviously the COVID situation has highlighted the need in the care homes again. And so we're just working with our primary care colleagues to review that again in terms of GP and specialist nurse input. But other than that, Nicola didn't give me anything else to feedback.
That's great, and I think care homes is such a big issue for all of us at the moment, isn't it? Particularly with people's concerns about capacity, staffing and winter moving forward. So I think probably it's our next discussion. We do need to just touch base on all the initiatives that are going on in care homes so that everybody's able to share everything that they are doing. But that's great, Emma. Thank you very much. Karen, how are you?
Oh, there we go. Fine, thank you. What have I got to update you on? Well, I suppose just a brief comment in terms of when David was talking about the clinical frailty scale app. I've been having a look at that, and one of the things I think seems positive about it is I think it's going to pick up frailty in people with dementia and mental health difficulties better, because it's much more around the functioning questions than the picture of someone with a walking stick. So I think it's going to be quite positive, because we often find our folk get underscored because people look too much at the visual clues for frailty. Aside from that, there's an awful lot of change going to go on with funding for people with serious mental illness across the country. I've just been on a big webinar thing this morning, and I need to sort of pick through how we need to work out that we can interface appropriately with that. It's in a nutshell, it's basically looking at bringing the care of adults and older adults with serious mental illnesses, so psychosis and severe depression and things like that, down to within a much more, for example, primary care network level, and trying to break down the barriers between primary and secondary care. And it all sounds really, really positive. The thing we're going to have to be really careful about is it becomes age attuned rather than ageless. And what are the interfaces going to be like with then other teams that are building up, such as frailty or what have you. So we're looking at that. In terms of that gave us a bit more detail on that. In terms of the mental health ICS, they're doing a bit of an overhaul at the moment, and I'm concerned that older people are going to get lost. And I've been raising this repeatedly, and it is being heard, but I might need to come back to some of you for a bit of help in terms of just sort of boosting older people's voice, and the fact that older people, particularly those with frailty and multimorbidity, have differing needs, because I think again there's this move towards, because this document about functional mental illness is talking about all adults and older adults. Okay, there's a lot of positives that could become from that, but there are risks as well for our folk. David Hambleton, who was the lead for older people, isn't in post anymore, so we don't have a lead for older people within the mental health ICS. So I'm quite concerned about that, and I'm trying to push for that to be reinstated. And also in terms of the documentation, there's been a couple of steering group meetings that I haven't been part of, because I'm a bit further down the chain, but dementia seems to have completely vanished. So I have shouted loudly about that, and we'll keep you informed.
Right, that is a real concern, isn't it?
It's a massive concern. And then I was interested, I had a word with Leslie, because then having raised some concerns, there was some little notices that said notes in some of the things saying strengthen links with the Ageing Well network, etc., etc. And I was speaking to Leslie this is a couple of weeks ago, and said, have you heard anything from anyone? She's like, oh, no. So whether that strengthening links is just me or what, I don't know, but I will keep you updated, because I think we've got to be really careful about some of these interfaces.
And I think one of the things we could do, Karen, to support you is we're now sitting on the ICS programme leads group. Yeah. And I think that's an opportunity, and it's usually either Jen or Lou or myself who go. So we could actually pick up there, because we had a lot of conversation there about actually older people and frailty had to be part of every work stream. Yeah. That actually the interface with particularly frailty, but other I think learning disabilities and children with significant needs need to kind of be streams that go across all of them. So yeah. We can help play that in, and I think don't hesitate to contact us at any point, Karen, where you think.
Thanks, I will do. I've got a meeting on Monday with Darren Archer, who's the lead for the clinical networks for the whole of mental health, and then we sort of sit beneath him as older people. And I'll see what comes out of that, and I might drop you an email afterwards, just because I might have a bit clearer idea of the landscape come that point.
think that would be really helpful, Karen.
Thank you.
It sounds like some fantastic work going on, and it's good to see so much focus on mental health, even if it's losing older people slightly. We'll get that back on track, won't we?
Oh yes, I think it's just jumping up and down and fighting our corner, really.
Absolutely. I was in a conversation with some others this morning, and we were just talking about, even with the recent letter out from NHS England, some of the very complex challenges around older people, around mental health, aren't as easy to write a document on as getting plan care up and running. And sometimes I think that's why, I don't think it's badness. I think people aren't just sure. There's not one step that's going to make this right. So it is about lots of different initiatives. And I think just by the diversity of this conversation, we're hearing from everybody, you get a sense of we need to tackle this on so many different fronts. So really helpful, Karen.
Thank you.
Lynn, how are you?
Hi, everything's quite positive down in Hambleton and Richmondshire, which is good to know. We are moving forwards really well with the sort of integrated frailty model work that we've started to do. Now we're under the new centre of the Friarage and the community locality, working with the PCNs. We've had a meeting with the local CCG, and they're really interested in what we're doing. Our priorities at the moment are very much about crisis management, especially coming into winter. And one of the more exciting things we're trying to do is create a stronger link with community services and ambulatory care in assessment of people in a crisis, and how we can better support them to stay in the community, really. And into that is a lot around the care homes as well. And Leslie's been helping us with that and is going to come and speak to us as well. So yeah, moving on. And the undercurrent is some work around workforce enabling, where we're at with skills and education. I think we're very good in the community, specifically around using the CFS to identify frailty. I think it's then supporting staff in knowing what they can then go on and do once the frailty, the person living with the frailty is identified. So I think some of the resources we've seen today are really quite helpful as well. So that's where we're up to today.
And that's a really helpful update, and it's lovely to hear that. I mean, Lynn, it may be worth you linking with the kind of workforce team that Leslie Bainbridge is leading, because David was alluding to it. There is some really interesting pieces of work going on there about workforce around frailty, and it may be mutually beneficial just to have a conversation if you're looking at that at the moment.
Yeah, Leslie's been really helpful in signposting us with some of those things, and hopefully the conversation we're having later this month, I can pick her up with that a little bit more as well. So thank you very much.
No, that's fantastic. I just think these things benefit from all the different areas and what the challenges are, as well as bringing some of them together to solve the problem collectively. So no, that's fantastic. It's lovely to talk to you, Lynn.
Thank you.
Jane, how are you? I can see
I'm good.
Jane.
I'm here. Yes, I am here. Sorry, I've had to unclick everything. Right. Okay.
No problem.
I don't really know where to start, because obviously the conversation is a bit clinical for me. If I could just sort of highlight that Von is, we're currently involved with public health leads. I don't know if people are aware of this health inequalities impact assessment work that's being done in relation to COVID. Particularly focusing on the vulnerable groups, of which older people is one. Janet is nodding. Yes,
I am nodding. Yes.
So you know that's potentially something people might want to keep sight of, and the work that's being developed through that is being posted on the Knowledge Hub, which I can send a link to, and I also assume that linked to that there is this thing called C-Works, which has been launched, which is a kind of repository for discussion, tools, and work that's going on around response to COVID, but with a particular focus on inequalities. And there is an event coming up in October, which people are being asked to save the date if they wish to know more about that. So I'm just forwarding that to Anne Richardson, and presumably she can get it out to the rest of you, if that's of interest. Yeah. So Von is working with that steering group that's looking at both the direct and indirect impact of COVID on the vulnerable groups, and trying to support some actual engagement with some of those groups and some of the voluntary sector that are working with them. We are also what am I trying to say? Come on, Jane, focus. We have done a survey of over 400 responses from voluntary and community sector organisations quite early on in the COVID experience. It was undertaken between April and May around the impact of COVID on the organisations and their beneficiaries, which, you know, predictably showed significant impact on the sector in terms of staff, in terms of volunteer and staff capacity, in terms of funding, and in terms of impact on their beneficiaries and their ability to provide services to their beneficiaries. So, you know, it's a work in progress, but it's very challenging at the moment. On the positive side, I think the sort of community hub arrangements and the collaborations at local level have kind of brought the sector, the voluntary sector, closer to working with local partners around a more coordinated and partnership response, which has been encouraging. In terms of social prescribing, I just wanted to say that, again, social prescribing link workers have proved their worth, I think, in terms of contacting those who are shielded and providing support. And just launched last week, information has gone out to PCNs and the World and His Wife, I think, around a rapid recruitment support offer where from NHS England, where if they want to recruit more social prescribing link workers, which are part of some of the 100% reimbursed posts through the DARES, then they can actually get a local voluntary and community sector organisation or a CSU to do the recruitment for them, in other words, to take the hassle away, and that voluntary sector organisation will receive some small payment for doing that. But the intention is, during this COVID crisis, to try to, if you like, encourage and speed up the recruitment of social prescribing link workers, because everyone's recognising their value in the current climate. If anyone doesn't know about that and wants to know a bit more, then by all means email me and I can forward the information. I think I'm going to leave it there because I could go on all day. Okay, thanks.
Jane, that's excellent. Thank you so much. That was really, really helpful. And it's lovely to feel those. I mean, COVID has taught us some really important things. And I think you've described some of them. And I think it's important we think about how those build into the systems more sustainably. So that's brilliant. Jeanette, how are you?
Just unclicking myself. Hello. Yes. Good. Thank you. I'm sort of new to this group. For those of you who don't know me, I'm the medicines optimization lead for the AHSN, and I am a pharmacist by background. And I was keen to attend this meeting because you're probably aware that there's a whole raft of pharmacy teams out there now in PCN and primary care land. And one of the areas that they've been asked to look at is doing structured medication reviews in patients with frailty. So I was keen to understand how we can sort of link them in and make them aware of the sort of work that's going on around this community and practice, and ask you if there's anything I can do to help sort of like make those links in any way.
So I think that's a really generous offer, Jeanette, and we've had some really useful conversations about some of the things that are evidence-based in supporting people through this frailty journey from a medicines management point of view, and you clearly link both with the community.
I think she's gone again.
Oh, sorry, this is I'm doing my best. I've got my hotspot and my Wi-Fi on with the hope I don't disappear again. I'm so sorry. is there anything particular that you think would be a really useful way of moving forward, or would it be better for people to contact you to have an individual discussion about what was going on in their area so that you could brainstorm with them the ways that you might be able to make an impact?
Yeah. Well, I think there's a bit of both. I'm quite happy to continue to sort of like attend this group to see if there's anything that, you know, from a medicines perspective, that anything you feel that is an issue that you would like us to tackle or to bring to this group. But also, if there are any issues locally, I can help put you in touch with sort of like the local pharmacy teams and things, and just a plea to, you know, to link in where you can with some of this, because I think there's a lot of independent pharmacists out there at the moment that are sort of like wondering where to turn. So I think there's something about making them aware of the eye care work and everything that's all the tools and resources that are out there for them to help them work with these patients.
So, and Jeanette, that's really helpful, and we'll make sure your contact details go out with the notes so that people can contact you around medicines management, optimization issues. Are there any kind of nuggets at the top of your mind that you should just think people just check you're keeping an eye on this agenda from a medicines management point of view?
Well, certainly I think it's the PCN, because the DES, it's an important part of the DES. So it's ensuring that those, as they recruit more and more pharmacy teams into the PCNs, that they're using the local tools and resources, not trying to reinvent the wheel. So if there's, you know, like when you were talking, Paula, about using, you know, identifying those patients, that they're working on the usual local tools and actually linking in to those systems that you've got going in primary care.
Yeah, no, I think it's helpful, and anything that you think just generally as a heads up for people via this group, I think would be really appreciated, Jeanette.
Yeah, I will do. I'll keep you informed.
Thank you so much.
Thank you.
That's brilliant. I know guys had to leave us. Paula, I know you were chatting earlier about ESF, but is there anything you'd like to just chat about?
I think a lot of people have covered some of the areas, but in the for the areas I cover as a commissioner are Darlington, Hartlepool, Stockton and the Tees Valley CCG, so Redcar, Cleveland and Middlesbrough. And it was just really to say pre-COVID we had, and I know Jenny will probably add to some of this, is we had an ICP frailty group, and it was just picking up on Karen's message really as well, I think, because there was an evolving clinical strategy around the ICS work, etc. And then we're going into recovery. I echo probably what Karen's suggesting is frailty seems to have slipped slightly from that agenda, but we do know it's a thread through. I think we just need to make sure it's a very big voice thread through some of the new emerging recovery work that's going on. But in the South ICP, pre-COVID, we did have a number of, and I supported the ICP frailty work. We did have a number of outcomes that we all collectively were looking to work towards, and I know Jenny will probably touch on a lot of that for Darlington around frailty front of house, etc. Then COVID emerged and we kind of had to deal with the pandemic. So we have got plans to reconnect our frailty network in the South ICP and get back on track some of the pre-COVID conversations that we were having. I'm involved quite heavily in the primary care network and the development of the enhanced health and care homes models with the primary care networks. And again, echoing what's been said on the call around the LD, that's going to prove a huge challenge because the requirements in the DES, that's nothing new to people who've been around the older people's agenda. I think that model's been in place. It's been, then it's not, and then it's come back in. So I think we're comfortable with the older people's agenda for delivering that. But I think the LD, and so what we're doing in the South is we are setting up small task and finish groups to look at how we can manage the challenges of the learning disability agenda and make sure that they don't get discriminated against because the older people's approach won't fit the LD. We've got to make sure that whatever we do adds value to those individuals. So that's work in progress, but again, happy to share whatever learning we get out of that, because I think the DES doesn't quite fit that agenda for LD, but a huge opportunity to improve LD nonetheless. But we just have to make sure we can articulate that. And again, what a lot of people have alluded to certainly is just learning from the COVID, certainly around the care homes. And I think a big element for ourselves, certainly across the system really, is how that digital technology has been really critical, certainly around clinical monitoring, etc., and just how we grow that and develop it, and then what tools can be built into some of that technology is very much at the forefront now. I think, again, picking up on Jeanette from a meds optimisation, you know, it's how we make the system going forward work effectively. So I think, you know, it is about identifying those people with frailty, but there's a big system and infrastructure that looks after them. So from a meds point of view and digitalisation, you know, how we know that there's a lot of safeguarding issues around meds delivery in care homes, etc. So what we're looking at is, you know, the proxy ordering process for medications with practices, and I think there's massive early gains to be had if proxy ordering of medication happens in care homes, because, you know, you've got a very clear governance and assurance, but again, how people are rolling that out might be very different. So we're looking at the resource to do that, because the proxy ordering, it just rolled off my tongue to say, yes, we want to do proxy ordering in the care homes. But we know from some of the projects that have been running in Durham, it would be really good to try and have Durham on the call, because they've been a key lead in rolling out proxy ordering. And it doesn't take just a few weeks, it takes a long time to get that proxy ordering. And again, we're looking at the other initiatives, you know, that come down from NHS England, implement NHS Mail, you know, in the care homes. Well, yes, we can do that, but so what does it change? You know, how do we improve the care? How do we bring the care homes into the same systems that run along TUV, you know, the acute trusts, primary care? So there's a lot of work around, because we just tick the box to say, I think, and this is my view, is we just kind of, it feels that we say, yes, everybody's got an NHS Mail account in the care homes, but how do we use it? How do we develop pathways of communication and improving communication? So there's a lot of work I'm looking to pick up around that. And again, how we make the best use of the remote monitoring in terms of those virtual consultations, because we've got to have the system where it flexes now. You know, when we have that spike or when we just have an outbreak, whether that be just the normal winter norovirus in the care homes, because they are one of our most vulnerable group, and how we're able to pull out of a care home but still not lose sight of, you know, the care that has to happen for individuals. So very much, you know, we have learned a lot around the digital technology, and I think that's a priority certainly for us as a CCG, and I'm sure many others and people across the system, how we make that work more effectively. But I think we can't underestimate how much support the workforce in the homes need to take that agenda forward, because in all of our daily lives, I just have to pick up the phone and ring a helpline if I'm stuck with my IT. You know, they don't have the luxury of that. So I think it's really important that when we start to implement digital technology, that there is an infrastructure, an IT infrastructure that supports the homes. So again, anything that we're doing locally down in our South ICP and CCG area, would be happy to share. But I think lessons learned over the years, don't we? We just put in digital technology, but then no infrastructure, and we wonder why it doesn't give us the outcomes that we do. So I think that's certainly a key area for me and the partners I know that I do work with.
Paula, I think that's a very comprehensive update, and I think there's some really interesting things there. I'm sure Jeanette was really interested in the rollout of proxy dispensing, and again may well be able to offer some either support or sharing. So and your point about Durham was really good, but the learning disabilities work. So again, I'm sure you're happy for people to contact you, aren't you, if they're looking at similar things, but vice versa. I think there might be people who could certainly support this piece of work. Karen was talking about LD earlier, Jeanette was talking about medicine. So I don't know if anyone wanted to comment on it, because that was such a large area we talked about.
I must learn to be succinct, Janet. It's just not in my DNA.
But Paula, you weren't not succinct. I think you just covered an awful lot of material that wasn't a criticism at all. Great to hear so much is going on, really. I'll move on though. Yvonne, how are you?
Hello. Can you hear us? Yes, I'm fine, thank you. So from Age UK North Tyneside, obviously we've been quite busy very much at the sharp end as such. So there's not really much I can report on developments from that point of view. However, from North Tynesyde's perspective, we had started some work around the integrated frailty hub that the CCG were keen to get started, and there'd been quite a few sort of quite large scale events happened in the run up before COVID, bringing the whole sector together. So the CCG, the primary care networks, the primary and secondary care providers, as well as the local authority and all the voluntary sector. So we'd all come together and started discussions. Obviously, COVID suspended all of that, but just in the past, I think probably the past 2-3 weeks, the CCG have restarted all of that dialogue. So we've got quite a few working groups undergoing, looking at the digital platforms, about the patient passport. We're also looking at MDTs and how we do things like planned responses, triage. So we're looking at the whole referral route and the whole combined service pathway. So that's sort of work ongoing. So at the moment, I haven't really got much of an update other than to say it's restarted.
Which is very positive, isn't it, Yvonne, to feel that people now are trying to make some of these things, and they're learning from COVID, and all the work that Age UK has been doing almost certainly will feed into that view on the hub, which, you know, despite the challenges we've all had, I'm sure will be beneficial moving forward. So that's fabulous, and thank you very much.
Yeah, so work in progress.
Keep going. Dan, Jen, do either of you want to comment on any of the local things or any feedback from your perspective in the core team?
There's nothing specific for me. The only one thing very briefly, which I'm just trying to get to grips with, is I've been invited to attend North ICP Aging Well Workforce Strategy meeting, which seems to be funded through Heaney, and I'm trying to work out where it all fits in with the wider stuff that's going on, but I've tied Leslie into it, so hopefully we'll not miss any sort of opportunities to bring it all together into this group and things. But I'll just keep you posted on that. There seems to be some data people involved, some population health management and wider groups, so I'll just let you know when the next meeting is next week, so I'll give a report back after that.
That's fabulous, Dan. Thank you. Jen, anything from you?
Only to say that I think there's been some fantastic work that's happened during COVID. It's been a real trying time for some of our older people, and certainly for our frail older people, whether they've had COVID, whether they've been shielding, and the real struggles that people have had. But people have been really innovative in terms of how we've tried to keep connected. And there is such a lot to learn and embed as normal practice. And it really has brought frailty back onto the agenda, I think, albeit that, as Janet said, it's easier to put plans and things around restarting planned care and elective stuff rather than this stuff around frailty and older people, because it's a bit tricky. It's not easy, but I think we've got some real good foundations on which to build it, and the relationships that have been built up over the past few years within systems and within areas really did come to fruition during COVID, or that was my observation, and we were able to support people. We didn't get it right all of the time, and there'll be lots of lessons learned, but actually I think overall you know, we've done really well, and we shouldn't forget that.
No, that's a very good place to kind of finish this roundup on. I just want to check, is there anything anyone wants to say that hasn't been covered in the kind of sharing information? I've noticed a number of people are sharing things through the meeting chat, which is really, really helpful, and we'll make sure all those comments are incorporated in the notes as well. But it's just great to see people kind of sharing other opportunities for either support or sharing information. So thank you all for contributing to that. I'm going to carry on down the agenda then, if that's okay. So the next item is to talk about the healthy ageing funding that is coming from the centre, and Cumbria and the North East have received some healthy ageing funding. The decision this year has been that the core team, so Jenny, Dan and Leslie, their roles will be funded out of that, but the remainder of it is going to be given to the 4 CCGs in Cumbria and the North East, along with a suggestion on how we move forward with the healthy ageing agenda, but allowing local areas to really think about how they do that. We were hoping that we'd be able to share the letter with you today that we have drafted with NHS England. My understanding is it's been signed off by Alan Foster. We're just waiting a bit of detail. But what the letter asks for really is for people to think in their area that the amount of money is about 160,000 between the 4 CCGs. So it isn't going to set the world on fire, but it is an opportunity to plump prime some of the systems, some of the start against the challenges in each local CCG area across the system. And there will be a timescale in the letter for a suggestion on how CCG will use that money to come back into NHS England. I think we were quite pleased with the approach that NHS England have chosen to use, because it hasn't gone down a very bureaucratic route. It is very much aimed at the local ageing well community getting together and working out how they can use this money in a way that starts to move them forward on many of the things you're talking about, on some of the system issues, with a recognition that we're expecting more money to come down this route over the next 2 or 3 years. And we would hope this starts putting you in the best position to know where that money will make the most difference in your community, looking at your metrics, looking at how your system's working now, looking at what the evidence is about things that improve systems. And you've all been talking about that. I think you'll all have some really good ideas about the things that would actually make a difference. And in the letter, it will say that the core team are really happy to provide any support. So if a conversation would be helpful about ideas or metrics or what other people have done or what national evidence is that's not accessible to you, then it would be great to hear from people. We're not quite sure when the letter's going out. I had hoped it would be this week. But what we will do is, as soon as the letter's gone out to the chief execs of CCGs, we will send a copy out to the community of practice. So firstly, you'll know who it's gone to in your area, but secondly, you will have a sight of exactly what the money is and what's required. So hopefully that allows you to help link that process together with what you're doing locally.
Janet, sorry, can I just come in there? Because I think it's really important for colleagues on the call and as a community of practice or a network to recognise that actually you guys and us collectively were able to influence NHS England on how they have decided to allocate that funding. So you'll remember that we came and asked you a while ago now, probably 6-8 months ago, about how that funding should be used and delivered. And actually what you said was actually it needs to come down to the local system so that we can agree what to do with that on a local level, and they have listened to us. So I think that is an indication that actually doing things through a community of practice or through a network actually does enable our voice to be heard and be listened to. So I just want to say thank you to all of you for feeding that back, because it is going to give us, hopefully, although this year not a huge pot of money, but over coming years there is lots of money coming down from the centre around frailty, and being able to identify how that can be best used in our areas, I think is a real credit to us. So thank you.
Yeah, that was very well said, Jen. I mean, I think what is fascinating is there is no one size fits all either in terms of the solution. So we know there will be a million ways you could spend this money, and locally you will have a view on what will make the most difference in the short term and facilitate the longer term. And I think that's what we're really proposing is the way forward. So we will keep you completely in the loop, but please make sure locally you influence this and actually it helps you do some of the things you've been talking about today. And if we can be of any help, or you want to touch base with us about this at all, because my understanding is the plans will be coming back to the core team to sign off in terms of them fitting with the overall national agenda on what makes a difference, just to make sure that the solutions are evidence-based. So early conversations and any support we can give you in any way at all, please let us know. Okay, so I hope that's all right. Dan, I think I'm moving back to, oh no, Jen, I'm going to you now, aren't I, for the PCN and linking together?
Yeah, so I've not got a huge amount to say, but I was asked just to think about some of the work that we've been doing with some of the PCNs. And whilst we had started work with the wider PCNs pre-COVID, during COVID, that's been nigh on impossible, and all of our attentions has been elsewhere. So I can really only share what we've been doing across Durham and a little bit of Darlington, because that's my kind of home patch. So forgive me for the Durham-centric piece. But there's a few things that I thought would be useful to share with colleagues, and that's around some of the metrics. So you'll know that we've got some regional metrics which we share on a regular basis, looking at CCGs, and we are working with the teams to try and get that on a PCN basis going forward, and linking that with some of the population health. So again, thinking back to that previous conversation about the money, that will help us identify in those PCN areas where actually the need is and what we should be doing to look to support the better outcomes for our frail older people in those areas. Certainly for Durham, we've looked at that wide set of metrics and have actually narrowed it down to nine metrics that the PCNs are going to use to see how they're kind of doing as their monitoring system. And 6 of them are absolutely straight from the regional ones. But I think it's really interesting that they've picked 3 looking directly at workforce. So looking at vacancy in community nursing services, morale amongst community nursing staff, and then also looking at therapy provision, both for acute and community, all recognising that actually if we don't look after our staff, we haven't got anybody to look after our frail older people. And I think that's really important. So again, something for us to think about regionally as to whether we want to look maybe at some more workforce focused metrics going forward. There's been lots of discussion and angst around MDTs and PCNs and the enhanced health in care homes work. And I'm really pleased to say that actually we've had some real success with that in Durham, up in Derwent side. And it's still early days, but actually we had a GP trainee with a frailty hat on that we placed in a dual role between the acute hospital and the community TAP team, so our teams around patients, and also the GP practice. So we had a trainee that straddled all of those during his working week. And actually through those links, he was really able to start and set up a true MDT up there for their patients and their PCN. And that included social workers, CHUV, district nurses, our community specialist practitioners, which are our community sort of frailty nurses, therapists, and also people from the voluntary sector. And interestingly, because obviously we were then launched into using Teams, actually that IT meant it was easier for people to come together, because actually driving or getting those people physically into one place was often a challenge and people wouldn't show up, but actually they were able to partake, and actually that's been a real success. And it's been really well valued up there, and it hopefully maybe at a meeting in the future, if helpful, or if people are struggling with setting up their MDTs, we'd be happy to come and share our experience and our learning to date. In terms of the enhanced health in care homes, I actually wanted to highlight something that Paula and the team down in Darlington did, which was a listening event with care homes, which I think was extremely helpful, and that was done as a system. So again, including the PCN, but also other partners, social care, the acute trust, etc. And it was a real opportunity to really listen and to really hear some of the positives, but also some of the challenges from the care home staff. And actually, I think there's something there about actually really listening and hearing, and not thinking about the DES as something that is very tick boxy, but actually what is it that we are really trying to deliver? Because we can all deliver a tick box exercise, but actually what really matters to those people and those patients and those carers in those care homes. And I'd really encourage other areas to do something similar in conjunction with their PCNs and their wider system. And then the last thing, which really was just linking back to that, the population health data, and trying to get that at a PCN level, because that again is that data is what's going to really tell us what we need to do and give us an indication of how we could do it. But it's going to take some bravery to actually switch from what is we still kind of are pulled down a current traditional route of delivering care, and actually being able to really just stop and look at what the data is telling us, and think about how we are deploying services, how we are identifying patients that really do need help, and really thinking creatively about how we access those patients, and actually how those patients access us, which I think in the digital age which we now find ourselves in is going to be a really interesting one, because that whole inequalities agenda is potentially going to create a different inequality in terms of the digital access, as well as potentially opening up opportunities for other patient groups. And again, we just have to be mindful of that as we're making our plans. So that's just a quick summary from PCNs.
That was really helpful, Jen. Any questions for Jen on a brief update on some of the issues in PCNs and linking them to the rest of the system? Thank you for that, Jen. So I think we're on to any other business, Dan. So Dan, I've got you down for doing any other business.
Apologies, you've got me down for any other business, Janet, or for leading it, because I've got no other business at the moment.
You're on the agenda for leading it, so
all right, no problem.
I'm going to let you do that.
Okay, well, let's shout if anybody has any other business. We've been quite comprehensive what we've talked about. Is there anything that you think we haven't specifically covered through the agenda? Anything that you think you need more information about, you need any sort of contacts for, anything like that? Just put your hand up, we should be able to see. So I've got Karen.
Yeah, I was just wondering, I'd seen some stuff coming down from at a sort of national level with talks about splitting the ageing well into a bunch of different work streams, and I didn't know how that, in terms of what was the one that was, there were one about anticipatory care and things, I can't remember the names of the other ones, and I was wondering whether that's something people are aware of and how much that national level work is going to impinge on what we are or aren't trying to do locally.
I have to say it's not something I'm cited on, Karen. I'm aware of lots of different work streams kind of feeding in under that agenda, but I wasn't aware of splitting it. I don't know if anyone else is more up to speed.
No, I wasn't, but what I'm fairly confident, and again, Janet and Dan, come in if you think I'm speaking out of turn, but actually the conversations that we've been having with the region in terms of the ICS over the sort of more recent weeks have been much more constructive in terms of ensuring that anything sort of ageing well-esque like does come through us. So that actually we can use you guys and ensure that the right people get to hear about things in a timely fashion. So if there is a push from the centre, so nationally, about doing something, we wouldn't necessarily be committed to doing that if we didn't feel it would fit for the North East and Cumbria. And my sense is that we have a little bit more influence in terms of shifting that, you know, if we don't feel it's going to work, and that's where this group potentially will really start to make its mark and influence that going forward. And that's part of the reason for the letter that Janet alluded to, in terms of how do we ensure that this group really gets embedded within the ICPs, and then the localities sort of that make up the ICPs, and how that then feeds up to the ICS. Because I think we have to remember that our ICS is the biggest, and actually our ICPs are actually ICS sizes in most places. So we don't want to add any additional layers of bureaucracy, but equally there are potential opportunities for sharing learning across the region, which is why we want to put stuff almost back down to an ICP level, but ensure that we have some sort of oversight of it from an ICS level. Does that make sense?
It does. I'm just slightly concerned that things might be running off. It seems that there was a lot going on, all of a sudden, a flurry of activity at national level, because what had happened was I got invited to be part of a I can't remember if they were calling it a community practice or something else, to do with the anticipatory care element of this, which, you know, it was positive that I was sort of volunteered rather than invited. Problem being, it was like, it was such a big time commitment. I couldn't, I said, I had to say no. It was a 2-hour meeting every fortnight with then lots of additional stuff around it. So I wondered if all that amount of work was then suddenly going into lots of different things that being broken down in a somewhat different way to how we were, and just more to be aware of it going on rather than, you know.
Dan, on any of the, because I know you've been dialing into some of the national calls through COVID, does that ring any bells with you?
It hasn't, to be honest. What I heard previously was they were trying to bring things together rather than separate them out, to be very honest. And through I was originally on the sort of the independent sector calls, and they've brought that together with community service calls. So if anything, from a regional level, they've brought it together. What I will do though is I'll put a couple of feelers out, Karen, just to see if there is anything.
I'll find the thing I was sent and forward it to you as well.
That would be really helpful.
Perfect.
Thanks.
So have we got any other business from anybody else?
I think the only thing that I just wanted to flag really, and it was coming back to Janet's reference to the letter, is, you know, when that letter does come out, we really would encourage you to read it and make contact with people in your ICS and ask those questions about, you know, so what does this mean for us? And actually, because you know us as a core team, actually, you know, make that offer, you know, that offer from us is absolutely genuine. But often it's just knowing who the right people are. And I obviously have good contacts in the south. I have some in the central. Obviously, Dan and Leslie have covered the north, and we know we're pretty void in Cumbria. So we really are relying on you guys to help us and put that offer out, because it absolutely is genuine. And we really do want to help. This is very much a grassroots, bottom-up approach, not a top-down approach. But to make that really happen, we need your help.
Absolutely, and do influence it. I mean, you the guys who are attending these meetings know what's going on, so really do get your message across. That I know it's not a lot of money now, but getting the process right for the subsequent years could be good as more money comes down this way.
And those of you that are supporting coppers, actually it's as important, if not more important, that you use that letter as, you know, as a way of you asking, you know, so what does this mean for us? What could this mean for us? How can you, us, help them deliver what they need to? And that's the way we framed it, so that hopefully it will open those doors and open the minds to a very different conversation that we think needs to happen from a frailty perspective as a system.
And to be honest, if it doesn't achieve that on this occasion, then it'll be much more difficult to fight for this approach again. So I would really welcome people just coming up with some really local, innovative schemes that fit with the national framework, and hopefully that will make a real difference locally, but also tell people this is the way to work. Great stuff.
On the call about the mental health funding and things this morning, they were talking about some of the areas that had done pilot sites and around Somerset and Sheffield and things, and they were very much saying that those working relationships and systems took a lot of time to build, longer than they anticipated, and them being in place already and a bit more mature was a massive benefit when, as you say, additional layers of funding are coming down potentially on a year-on-year basis.
I think it's so true.
And we don't want it to get stuck in that bureaucracy.
Absolutely, Karen. If you look at just going back to the PCNs and the MDTs and all that, if you look at what the British Geriatric Society talked about, was the first year really should be about building relationships and trying to get people to work together and use resources to do that, rather than worrying about all the actual delivery model per se, because that's the sustainability element.
Yeah.
Excellent. That feels like it's been a really thorough conversation today. There is nothing else on the agenda unless anyone else has got any other business that they haven't told Dan about. So on that basis, I'm going to conclude the meeting. We meet again in October, I think.